Okay. So hi everyone, good afternoon. I hope that I am live, audio, video both are fine. Okay, so guys, I am Dr. Sushil, your orthopedic faculty at DBMCI, and today I am here to discuss with you the INI recalls, right? And so I would like to just tell you that these are the memory recalls that every student has been like telling us that what all were the questionnaires in your INI, and I'm very glad to see the questionnaires of orthopedics. These have been the questions which you have been like doing regularly in your classrooms, isn't it? So when you are a part of like normal teaching in our classrooms, whatever notes you are making, whatever important topics you are highlighting, important points you are highlighting, these are the questionnaires of your INI exam. So I don't think, yeah, common peroneal nerve question. Yes, Sairam, I'm just going to discuss all of that. So do correct me wherever you feel like the options were not same or the language was little bit like changed. Do let me know. And the most important thing is I would like to share the images of our eGurukul notes also along with them, which you can see that the questions are a part of your daily routine classroom teaching itself, right? So let's start with that. So I hope it is all getting relayed very properly. What happened here? Yeah. Test for. So Sairam is telling about trendelberg, gluteus medius minimus action was asked, okay, and only abduction medial rotation is not there in the option. Okay, perfect. Thank you, Sairam, for your inputs. Let's start. So we have just, my team has compiled all the questionnaires of the INI exam, the part 1 and part 2, and some of the questions in the like exam, part 1 and part 2, I think there was some repeats there as well. So let's see, we have compiled the file as a whole, both the papers, okay. Yeah, so Trendelenburg, as Sairam is saying. So first question, guys, it was a nerve getting injured due to fracture neck of the fibula. So you all know, right? This is a part of our topic in our classroom, which we read as what? The entrapment neuropathies, isn't it? The topic that we read in our classroom is entrapment neuropathies as a part of the peripheral nerve injuries. So this was a question which is very simple. The entrapment neuropathies, that which is the nerve which may get injured, which may get entrapped around the proximal fibula, and that's only one nerve. You all know that this nerve which is over here, that is a common peroneal nerve, which when compressed leads to what kind of deformity? It leads to the foot drop. It leads to your foot drop. Okay, so this is the image. This one is the from eGurukul notes itself. So in the notes also, you know, we have been doing it. Taylor's muscle action for when hip flexion and abduction. Okay, so that was a Sairam, I guess that was a question of anatomy part, right? So let's see the next question here. The entrapment neuropathies guide, I would just suggest you that if you look at the previous few years of the questions of the INI exam, from the entrapment neuropathies, they have been continuously asking you the question. Let me just put that on record here as well. In the 2020 exam of INI, they had asked the question about the carpal tunnel syndrome, and they asked about it as most specific test, right? The most specific test for the carpal tunnel syndrome, they said it was Durkan's only, right? In the year 2021, last year I believe, they asked the question about the Roos test. If you remember, the compression of basically the lower trunk of the brachial plexus or the subclavian vessel, which you call as what? The thoracic outlet syndrome. So Roos test was your last year's question. And now in 2022, they have asked about the compression of the common peroneal nerve, that is leading to the compression of CPN, right? So they've asked about the nerve itself. So every year, you know, this entrapment neuropathy is giving one question in some of the exam, maybe in the All India, maybe in the INI exam. Okay, so that is one. Next one I would like to take, these are all the, like this is the short note, or this is a like a screenshot of all the description of the entrapment neuropathies that we have in our eGurukul notes as well as in our classroom notes as well. So if you see the carpal tunnel, this is what I was telling you, the carpal tunnel was asked and its test was asked, which is what you call as what? The Durkan's, right? So Durkan's test is the most sensitive, basically they said, the test for the carpal tunnel syndrome, right? So specific and sensitive, that Durkan's is the most important one. Okay, this was one. Second question was, book test is done for which of the following nerve? So now if you observe the last few years of the exam, INI exam, you know the test, clinical tests are being asked repeatedly, and you will be like amazed to, I believe you have already seen that, but you will be amazed to know that the test of the nerves, they have been in fashion for last 3 years continuously, right? Whether you are talking about the Froment sign or the book test has been a question in like 2 years back again. It was there. So now it has been asked. So this was the second time when the book test has been asked. And as per our eGurukul notes, your classroom notes, you know that the book test basically, why we do that? For the muscle, the exception muscle which is there on the lateral side, supplied on the lateral side by the ulnar nerve. So ulnar nerve coming onto the ulnar side and coming onto the medial side and ending here at this point is what you call, what muscle there? The adductor pollicis, making the thumb go like this. Making the thumb go like this. That is adductor pollicis. Okay. So this was the book test is done for which muscle? The adductor pollicis. We know this. And this adductor pollicis muscle is an exceptional muscle on the thenar eminence which is getting a supply from the nerve of the medial side. That is ulnar nerve. Right. So all the thenar eminence, they are supposed to be supplied by median nerve itself. Right. All the thenar eminence muscle, they are supposed to be supplied by the median nerve itself, but this adductor pollicis being an exception here is supplied by ulnar nerve. What is a nerve? What is a muscle that is supplied here by the radial nerve? The muscle of the thumb here, it is the abductor pollicis longus, which makes what? Which makes the boundary of the snuff box. So these are two important questions which usually are asked in the exam. One is the abductor pollicis longus and one is adductor pollicis, right? This adductor pollicis muscle, how do we test it? You ask the patient to hold something between the thumb and the fingers like that. And in case the adductor power is weak, what happens? In case the adduction is weak, the patient is asked to pinch it up, right? Patient actually does. He is not asked, he does it. So instead of adduction now, he uses the pinching power. So when you are pinching it, it is a flexor pollicis. When you are pinching, it is flexor pollicis. And what is that known as? So if adductor pollicis is not working, the patient will be doing use of the flexor pollicis, and this use of flexor pollicis is given another fancy name, which you know as what? The Froment sign, which you know as the Froment sign. So which you know as what? The Froment sign, right? That is Froment sign. Okay, that was another question in your exam. So this is about the Froment sign book test, which has been an important question. Okay, next question here that we had in the exam. You are called to a newborn baby house to look at the baby. Okay, you noticed CTEV. And at what age, there should be a full stop here, at what age will you advise the baby's parents to get the cast correction for CTEV? So you know the cast correction principle is given by whom? What is the most commonest method followed for CTEV correction? We know it is what? It is known as the Ponseti's technique, isn't it? The Ponseti technique. And in the Ponseti technique, what Ponseti says about the CTEV? We all know that. Ponseti says start the correction of the foot for CTEV as early as possible. So preferably in the first week of life. Why? Because Ponseti says that the muscles, the tendons, the ligaments, they are highly viscous when the child is born, and as the duration passes, gradually the child basically, the viscosity of these structures, they start losing it. So start the correction as early as possible. That is the most important thing you should know, right? So within few days, if that is the option, please do correct me wherever you feel like the options were a little bit changed or so. So please do let me know about that also. So within few days, I would say, and Ponseti says that treatment should be started as early as possible, right? Treatment is to be started preferably within first week of life. Start the treatment preferably within first week of life. That has to be done. Okay, that would be preferably within first week of life, right? Now, this was question number 3 about the CTEV. Next one, what is the Sunderland classification of axon injury with endoneurium intact? Guys, if you recall, this was your previous year question as well, the previous INI question as well, if you remember that, right? So, what is a grade of injury where the endoneurium is intact and the axon is injured? So, you know this classification system here. Where is this? Yeah, this one. The Sunderland and Seddon's classification. So, the eGurukul note, snapshot here, your classroom notes, you know how we logically discuss this, that why a Sunderland's particular grade will recover in a best manner. So, what is a grade of injury? Where the axon is gone, but the endoneurium might be intact. We know it is a second grade injury. So, axonal injury plus minus endoneurium. So, minus endoneurium is type 2. With endoneurium, the grade 3 is axon with endoneurium, isn't it? Do you remember that? So, with endoneurium. So, this is a very, very basic concept. For that, how we start our lecture, the peripheral nerve injuries, we always start with the structure of the nerve, so that we know where the injury is happening. So if you know the injury layers are, where the injury is going on, you know what all you need to suture up, you know what all you need to recover up, right? So that is a grade of injury. That is second grade. Axon is injured, the injury to the nerve is there, but the nerve sheet is intact. That is axontomesis. So what do you call that second grade of injury? It is similar to Seddon's grade of axontomesis, right? That would be same. So if you have just revised your notes, if you have just seen into your notes, you know two classification systems for the fracture or the injuries in the nerve. It is the Seddon's and the Sunderland. Seddon's and Sunderland, right? You all know about that. Okay. So this was 4. This is the screenshot of the eGurukul notes where we have put this classification system over there. Right. So what Sairam has just said, the positive Trendelenburg test on right side, the lesion is on which side? So positive Trendelenburg test on right side means, what actually that means? So when you say the positive test is on right side, that means the right side is a failure. That means the left pelvis will not be staying at the same position and it will fall down. That's what you call the positive Trendelenburg test on right side. So when you are testing for right side, the patient is not able to keep the hip at the same level of the opposite side. So failure is of the right superior gluteal nerve. Now if you recall, it too, this question too is a repeat. Trendelenburg is in fashion from 2018. It is being asked in variable ways. Last session, if you remember, the last year, if you remember, how the question was asked, there was a cadaveric image given, and in the cadaveric image they have marked the nerve, right? And then they have given the clinical scenario, and in the clinical scenario they said that the patient is basically, okay, so they said the patient is basically, some patient is asked to stand on right side, the left side of pelvis drops down. So what they asked is, what was the affected nerve which is marked in this particular cadaver in the structure here? So in the cadaver they have marked about the superior gluteal nerve, and they asked you about Trendelenburg test only. So please remember true Trendelenburg. Why we do that? The gluteus medius, the abductor mechanism of the hip. So Sairam, I have taken your point here. Sound side sinks. Absolutely correct. You are absolutely right. So it is being done for the abductor mechanism of the hip, which is gluteus medius and gluteus minimus. Gluteus medius and gluteus minimus, right? So that would be gluteus medius and gluteus minimus. So that is about the positive Trendelenburg sign, right? Next one, what is that next one we had in this exam? So this is the screenshot of the eGurukul note. So in the classroom also, in the notes also, we always discuss about the Trendelenburg. So normal hip abductors, if they are there, image A, look at this. If the patient is having normal hip abductor on the right side, he will be able to maintain the other pelvis at same level. But in case the right side is a failure, other side of pelvis will drop down. That is what our Trendelenburg test is. That's our Trendelenburg test is. Okay, so Trendelenburg, it remains one of the most important topic for any of your exam. You should remember that it is always, it is repeated number of times. Number of time it has been repeated. Okay, next one. This was about the emergency requirement in an open fracture. Now, if you recall, so if you recall your notes of eGurukul of your classroom from the basics of trauma, how do we manage the patients of polytrauma? How do we manage different, injuries, different fractures? So where we discuss that, what are the different treatment plans we have in trauma? For example, immobilization only. For example, where we do plating, where we do close reduction, internal fixation, where we do open reduction, internal fixation, like that. So we have multiple areas where we discuss these kind of things. And then about the external fixator. Now guys, if you recall again, in the last few years of the INI, starting from the year 2020, 21 and this year, all the 3 years the INI started, every time it had asked a question about external fixation. If you recall, in the very first year, it was an image based question of the rail fixator. Do you recall that? It was about rail fixator. In the next session, they asked about that. All of these, which of the given 4 external fixator is having the maximum stability? Which of the given 4 external fixators has got the maximum stability? So they have given you 4 options: uniplanar rod and clamp, double rod uniplanar rod and clamp, multiplanar rod and clamp, and then they said Elizaro. So that was another question next year. So they asked about the stability of the external fixator. In this last session that we had, in the AIMS INI exam again, they asked a question where there was a fixator was applied in the femoral area, then there was a fixator applied in the tibial area like that, and there was a fixator applied like this, and there was an interconnecting rod in between them like this. And they asked why this fixator has been given. Is it for femoral injury? Is it for tibial injury or is it for intra-articular injury? So always remember it was about peri-articular injuries only, because that is why you are combining two different rods together, right? That is very much required. Okay, so Daydreamer is saying that in the afternoon session they again asked left side trendelberg is positive, which nerve affected on which side? Okay, so that might not be right side, might be left side, that's okay. So I'll just correct it like that. So I'll just say maybe on left side. So if the answer is on left, if the question was about left, answer goes automatically in favor of left only, right? So basic concept has to be very, very clear to all of us. Okay, so what is the emergency requirement in open fracture? You all know. Open fractures, there are 2 to 3 important things that you must not forget. One is about the classification system. One is about the classification system that we know is Gustilo-Anderson. You all know the classification for the open fracture is Gustilo-Anderson. You all know about it, isn't it? Then how do we manage the open fractures? It is all about the primary wound wash and the debridement. The wound wash with the primary debridement, no, that is what you do. And the emergency requirement always in a fracture, open fracture, is that you have to stabilize it. So here we don't have an option of like external fixation. So I can simply say that external splintage. Now what is the advantage? Whenever there is an open fracture or whenever there is a fracture overall, splintage has to play a very important role. What is that role? That it will help in decreasing your blood loss. Most important thing, it will help in decrease blood loss, or it will also help in what? Decreasing the chances of complications like fat embolism syndrome, isn't it? The more a big bone moves, for example femur or tibia, there will be higher chances of developing the compartment syndrome. So that's what we don't want. That's what we don't want, right? So external splintage of any fracture or any fracture, like not only open, any fracture is very much important and it is very much required. Okay. Then we had another question. About this. The patient is like 1 year, 3 months old. There was a question here which was not properly framed, but you help me, please help me in framing this question properly. So the language that we got, 1 year, 3 month old. There is a child, 1 year, 3 month old, and he can sit with support but can't stand. So basically they are trying to say that there is a delayed milestone. That is what they try to say. There is a delayed milestone. There is a delayed milestone, right? That is what they are telling. And white line, this is other milestones are normal but delayed. That is what they are saying. No, white line at metaphysis is there. 1.5 year, you can say 1 year, 3 month child is there who has got a white line at metaphysis with a hypodense epiphysiometaphyseal region at the wrist. Image was given. So there was a white line most likely which was given at the epiphyseal metaphyseal junction like this. So this was a white line given. Then they said what is a diagnosis, but in the question they are not mentioning whether the situation is painless or painful. So this again guys, it was a recall in 2020, it was a question in 2017, and now in 2022 we again have the question. But now here the thing is, a rickets is painless, scurvy will be painful, but the point is both of them they show you white line. In rickets the white line comes as a part of healing. In scurvy the white line comes as a part of disease, right? Now this white line they are saying, and there is a delayed milestone. So that might be a possibility that they are asking you about rickets itself, right? The mineralization disorders. So mineralization is low. Basically see achondroplasia, the defect is basically in the bone formation. Otherwise mentally the child is absolutely all right, right? There is no other milestone delay or nothing like that in achondroplasia. Osteogenesis imperfecta is also a disorder of your collagen, where the collagen basically is defective, and that defective collagen makes the bone get fractured again and again. So that has nothing again to do with the delayed milestone, but yes, rickets can have that. So most likely here they are asking about rickets only. So ALP was much higher. Okay, Anita is telling me about increase ALP. So I'll add on to that, Anita. Thank you so much for the input. Sir, widening was there in X-ray. ALP was 1500. Okay, that's great. So ALP was 1500. So that automatically makes it more in favor of rickets only. And then Anu has already also added one option. What was that? Widening was there in the X-ray. Perfect. Perfect. So another input is widening on X-rays. Widening on X-rays. So that makes it more in favor of what? that makes it more in favor of rickets. So thank you guys, both of you, to put input. White line of Frankel was there. Emergency requirement in open fracture was a multiple open question. Okay, Madhu, I just saw your this input. Can you please tell me the options over there? In Madhu, if you are like there with us, can you please help me in making the proper question about the open fracture question as well? And Daydreamer is saying that on question they gave, the child was able to stand. The child, okay, ALP was some 1000-1500, we'll take that range, that's okay. ALP was like 1500 or maybe 1000. So anyhow, that's elevated, that's a concept. So that goes more in favor of rickets only. Okay, so widening point taken, ALP point taken, and that automatically makes it go in favor of. Sairam is saying it is white line of Frankel. Was it mentioned in the question that it's a white line of Frankel? Did they mention it? White line of Frankel, guys, if you can provide me the input. Was it there? The white line, was it mentioned? The white line of Frankel. Was it mentioned? Was it there or no? So I don't think so it was there, because nobody told us like that. So if you guys, okay, perfect. So this one, so I'll go back to the previous one. You are saying it was a multiple option type. Okay, this was a multiple, okay, option type. It was a multiple option type question. Thank you for the input. Anita, yeah, internal fixation is there, IV fluid, antibiotic, external fixation. Okay, so this was a multiple correct option type question. Multiple correct option type question. Not mentioned. Perfect. Okay, great. It was not there. Right, so it was not there. So we can remove it. This was not there. Perfect. Okay. See, Trendelberg test is positive on right side is not a correct statement. We call it like Trendelberg test is positive for right side. Meaning by when you ask the patient to stand on right side, the left side pelvis will drop down. Okay, so normal side drops down. Test you are doing on which side? Right side, no. Left side is falling down. So which side is faulty? It is right side. Okay, I hope you got the point. Mr. P is there with us. Okay. Number 8. So these are all the screenshots of the like eGurukul, where we are discussing everything in the classroom. Like also we discuss the differentiation between the white line, the widening of the bone, the bending of the bone, the bowing of the bone, like that. So rickets, Malaysia, scurvy. So these are the screenshots of for the eGurukul, and you might have noted in your this class notes also. Okay. So simple paper till now, isn't it? There was nothing tough. There was nothing difficult. Okay, everything is like a basic concept, and in every class I have been always telling you to be focused on the basics and concepts. Whatever exam it may be, it never ask you hi-fi things. See, I always tell all my students that one or two question, if they are new, that doesn't like mean anything, because nobody else also doesn't know answer for that. But our fight is for the rest of the questionnaires, which usually comes from the basics and the concepts only. So guys, stick to the basics, stick to the concepts, and that's the key. Okay, so next one, terrible triad of knee. Come on man, I think you all would have answered it very correctly. So straightforward question. So you know, we have got two type of like terrible triads, one in the elbow area here, one in the knee area. You all know that. So when you talk about the knee area, the terrible triad of knee, what are the structures which are injured? Okay, so the structures which are injured, the terrible triad of knee, you know that they are starting from the medial side, then into the ACL, and with the flexion, it is the medial menisci. So all the three structures getting damaged together, it was your terrible triad of the knee. When you talk about the terrible triad of elbow, you all know what about the elbow, terrible triad of elbow, the Hotchkiss terrible triad, it is the elbow dislocation. It is the elbow dislocation with radial head with coronoid, isn't it? Elbow dislocation plus coronoid plus the radial head. So all the three getting together, okay, it was an image based question. Okay, got your point. So this was, I'm writing it down, this was, can somebody please share with me? I'm very much available on the Telegram. You can just search me as Sushil Vijay, or on the DBMCI Premier group, right? Or on my group, anywhere you are comfortable, please share me a simulating image which was there in the exam. This was a image based question. So in the image based question, guys, then even I believe you are easily able to see that there is a dislocation going on. right? Isn't it? There was a clear thing. It was a terrible triad was a question of morning or evening session. I can't remember properly if it was there in the morning. Someone. It was to identify in gross section. Okay, it was an image based question. Terrible triad of knee, Sayam Jyoti Mandal, as it has been like conveyed to me, it was a question most likely in the evening hours. It was not of the morning. So gross section of the knee to find terrible triad. Okay, it was a cadaveric image. Okay, point taken. It was a cadaveric image. The question was, yeah, it was an image based question as told to me. Not in the morning, sir, tried. Yeah, it is in evening, Sairam. Everybody is telling no. So everybody has put the input here that they were in the morning or evening hours. So initial questions that I have taken up, they were a part of, I think, morning hours, and now what I am taking is the evening hour question here. Okay, so not in the morning. Okay, so this is about the terrible triad of the elbow or the knee area, right? So next one is right. So evening hours we had a question on giant cell tumors also. Okay, we had a question on. So this is again the screenshot of the eGurukul. In your classroom also we discussed the basic thing about the terrible triad of elbow also, terrible triad of knee also, right? Next one, number 9. There was again a question most likely on GCT, and I just fail to understand why the AIMS people like don't know the tumors other than GCT for last so many years now, starting from 18 when the INI was not even there. Even then there was no other question in the exam other than GCT, and for last so many sessions regularly we are getting the questions only on GCT. Why so? I fail to understand. So maybe, but anyhow, this GCT they said that these were the options as have been told to me by the students, that this was 30% cases metastasized. Is it so? The very first statement is wrong. We know that it is GCT. How do we know it is GCT? Because we always discuss in the classroom that the first thing to be seen in any bone tumor is what? It is the location, and here the location is what? The location is epiphyseal, right? At epiphyseal tumors are only two. One is GCT, and that is other is what? The chondroblastoma, isn't it? The giant cell tumor and the chondroblastoma. So GCT and chondroblastoma. Okay. Then you have the second point, the 30%. Do they metastasize? Not actually. These are GCTs are what kind of tumors? GCT you all know are locally aggressive tumors. GCT are locally aggressive tumors, isn't it? They are locally aggressive tumors. So they go into metastasis less than 5% cases. Okay. So was it a multiple option correct? Again, Anu is saying that it was a multiple option correct. Is it so? Can anybody please provide me the inputs on that? So epiphyseal location is true. Both A and B wrong. Ground glass appearance on X-ray is diagnostic. Not exactly. It is not diagnostic. So only one option is correct. What they asked was correct statement. It is epiphyseal location. That is the only correct option we have. Okay. Options were different and lengthy. Okay. Point taken. So this was a screenshot of the, this is one behind me, the screenshot of the eGurukul notes. Okay. So please can somebody help me in like reaching to some options of the GCT? If they were lengthy, that's okay. If you can please just tell me about that. Somebody can provide inputs on that. Okay. So by the time you put some options, if possible for GCT guys, they're on the Telegram group. Please do share with me the simulating kind of images or the questionnaires, the options if you want to contribute to it, so that it can be beneficial for all of the students. I'll be just putting all the INI recalls in the eGurukul app very, very soon. Okay, and that is why we need your inputs to have the correct language of the question. GCT again, but in depth, it was tough question, sir. Okay, great. P, I take your point. Please help me to make those languages, and all of us together on the YouTube right now. I think we are so many, and we can improvise a language. All those who have given the exam in the evening session, we can improvise it. There was an option like most common in 40 to 60 years. Okay, so one option you are saying, one option input is most common in 40 to 60 years. Most common in 40 to 60 years was one of the option. Okay. Next one was a 6 years old child, lateral condyle humerus fracture was given, and the fracture united, but gradually he developed a deformity. Okay. Which of the following sign you expect to find in this patient? What do you suggest? A lateral condyle, usually you know it goes into non-union, but in case they are telling that it is already united or gone into union, that's a fantastic thing. But we know the lateral condyle, if it has been managed conservatively or surgically, it again has chances of getting into some deformity around the elbow area. So the most commonest deformity that is seen around the lateral epicondyle or the condylar area with non-union is usually a varus. And when there is a, valgus, not varus, my bad, the valgus. So when lateral condyle is not uniting, it goes into valgus. So when it goes into valgus, all the medial side structures, they start getting stretched. And we know that there is a ulnar nerve, and if the ulnar nerve is getting entrapped, and the nerve, if the ulnar nerve is getting entrapped, you know that the median two side of fingers will be involved. Ape thumb, not possible. Pointing index, not possible. Wrist drop, not possible. Loss of adduction, abduction of the fingers. Why? Because we know that it is C8, T1 and supplies what? All the intrinsic muscles of the hand, and that is why it can cause loss of abduction, adduction. That's very much true point. Can be like possible. Okay. Okay. Perfect. Perfect. This one. Right. Point taken. So you are discussing about the GCTs right now. So 20-40, not 40-60. So I don't know, whatever you suggest, I can put up the, this will help us. So most common in 40-60 is a wrong statement. It is in 20-40, that is a correct statement actually. Right, second to fourth decade, that's a correct. So I excluded that option. So, okay. Next one. It's not like that GCT cannot occur in the 40 to 60 years of age. It's not like that. Okay, the most commonest age group is 20 to 40. It's not like that it can never happen. Okay. Next question was a 65 years post-menopausal female. 65 years post-menopausal female came to you with a history of persistent lower back ache not responding to conservative management. She feels the pain started 4 months back, so chronic kind of case, while she lifted a heavy bag, and now she has significantly, it has increased. The pain worsens as she walks and even starts radiating to the right leg after walking some 100 meters. She, however, feels better on walking uphill, that's okay. She wished to know the most likely possibility, and the student told that there was a image given somewhat like this, right? They were given some image was like this. So in the image, what do you observe? What do you observe here? You can see that this vertebra and this vertebra, the upper vertebra is somewhat slipped over the lower vertebra. What do you call this situation? It is spondylolisthesis. So I believe the question was on spondylolisthesis, and this listhesis, you know that lysis or listhesis can have usually what complaints? The complaint they usually have is what? The backache. The backache which may be accompanied by what? Backache with radiculopathy. Right? So that is what the lady is suffering. So now they are trying to deviate our attention by saying that she's an old lady, she is postmenopausal. They want to just put your attention towards what? Osteoporosis. But the picture is showing you the slip of the vertebra. So when the slip of vertebra is there, we know that vertebral osteoporotic compression fracture is not there. PIVD is a possibility, yes, but that disc will not be related basically to this slip of the vertebra. So basically it is isthmic spondylolisthesis. When you say isthmic, you all know that when you say isthmic, the defect is where? The defect is at pars interarticularis, isn't it? The defect is at where? The pars interarticularis area, right? So defect will be at pars interarticularis area. Okay, so that is one. Okay, so I can see your option you have put. Emmy has put the option osteoblastic drugs are given in neoadjuvant therapy. Okay, that was another option. Okay, I'll write it down. So osteoblastic drugs, you are saying osteoblastic drugs given in neoadjuvant therapy. In neoadjuvant therapy. Okay, that is point is taken. Right, that point is again taken from here. Okay, so this was your question number 11, and the image which was given was most likely a listhesis. That's how the students have provided us the image with. So don't get carried away by just the age, by just postmenopausal status, by just they're trying to just deviate your attention towards osteoporosis. That's not a good idea, right? And then we have this question, a patient has come with Klumpke's palsy, involvement of the lower trunk. You know what? Lower trunk, basically, the roots, lower trunk is made by what roots? C8T1. That goes or makes the lower trunk, right? So patient has come to you with the lower roots injury, which is Klumpke's, not the involvement of the lower trunk actually. Will C8T1 lead to what? Ape thumb? Not exactly. Policeman's tip hand? Is it so? Not exactly. This is what? This is Erb's palsy. This is median nerve injury. Okay. Wrist drop is for radial nerve, and the claw hand is for the C8T1 basically. Right, and complete claw hand is only seen when there is a Klumpke's palsy or when the ulnar and the median nerve both have been injured at the wrist area. Then only it is seen. Okay, so yeah. Okay, so that is a Klumpke case, again a screenshot from the eGurukul notes. So all the questions were basics and simple. Another question was, I believe it was an evening exam question, evening time question only. Patient presented, no, this is a repeat I put. CTEV we have discussed point. So this was another question about the CTEV. Choose the correct sequence for correction of CTEV. So whenever we talk about CTEV, we have talked about CTEV either in the eGurukul videos, eGurukul notes, and even in our classroom. I always told you, CTEV correction is just a block game. Align the blocks very, very correctly and very, very, in a sequential manner. And when you correct the blocks, the foot will be automatically corrected. So that's how you correct the CTEV foot. Okay. So basically what is the sequence? The sequence is correction of the first arch, the first basically the Cavus, which is there due to the first metatarsal, then correction of the adduction, then correction of the varus, and then correction of the equinus. Okay. So cave is the sequence to be followed. Cave is the sequence to be followed for correction of, so cavus, adduction, varus, and eversion, like this one, equinus, eversion. Is it so? Actually no, the options provided here to me are not correct. It should not be eversion, it should be actually equinus, right? Equinus. Eversion is not a deformity in CTEV, that's wrong, no? So this is the best option which I think is there. Radial nerve has supply from C5 to C7, so spared. Okay, perfect. Okay, right. So these are the questionnaires, guys, and these are the screenshots from the eGurukul, and I need not say again and again that these were from eGurukul. The question paper was simple. It's nothing extraordinary which has come, and you all have the basic concepts in your hands in the form of your notes, the class notes and the eGurukul notes. You already have that, isn't it? So these were the questionnaires provided to us for the morning session and the evening session of the AIMS exam, the INI exam. And this was me, Sushil Vijay, your orthopedic faculty here at DBMCI. And guys, I do believe the AIMS is done, the INI is done, and you are just, with the whole heart, you are waiting for the results. And I wish you all the very, very best. Let's hope for the best, and I do believe you are going to make it. So I'll be waiting to hear from you, the results, the ranks, your wherever you are joining, your college seats. So just provide us the happy news as the result comes. Okay, so my bestest wishes to all of you guys. So stay connected, and we are very much there on all the social media platforms to help you out for any kind of academic assistance you want. Okay, and just in end, we are having this 5th of March as our All India Day, the NEET exam which is proposed there on the 5th of March. So I would just like to announce another important, very important thing to you, that all those students who feel like that they are done with all the 19 subjects, but they still want to revamp their preparation, they want to fasten up their revision program. So we are coming up with the mega power course, and it is starting from 18th of December. In the state of Bangalore, in the state of Hyderabad, we are starting a bit early in the first week of December itself, and in November, basically in Hyderabad in November itself. So the mega power course is basically meant to revise all the 19 subjects in a very, very short span of time. All the details, all the concepts, all the basics, all the previous year MCQs, and everything that you need to crack the NEET examination. So if you are the one who is looking for a source to revise all your content, then guys, this is the opportunity. Okay, by any chance, if you have been a student of some other platform, online platform, and now you wish to study, you wish to read from the legendary Dr. Ashwani, or we know the legend himself, Dr. Tamim, Praveen sir, if you want to read from them, then all the 19 faculties are coming live to your centers as well as on the DBMCI live platform. Yes, you heard me right. The mega power course will be an online program as well. So online program is starting on 18th of December, the complete details of which you can very well see on dbmci.com. Just go over there, click on the mega power course, and you will get your center detail, your complete schedule, the list of the faculties, and everything that you need to learn the way to revise. Along with that, obviously, when you read from all the 19 faculties, your content is done, your revision is being done, and you have ample time in between so that you can do your complete Q bank, right? So Q bank, SWTs, GTs, they all will be incorporated as a schedule. Then only the things are going to be fantastic. So if you are the one looking for a quick recap, mega power course is for you guys. So just for the details, connect with your center partners, the face-to-face center partners, Pan India, and on DBMCI live platform as well, online platform as well. Okay, so in case by chance you need any academic assistance from my side, I am very much available on all the social media platforms. We are there on the eGurukul's medical Facebook. We are there on DBMCI Premier Group, on the Facebook as well as on the Telegram. I am there on my Telegram group. All the eGurukul, all the Telegram groups of the DBMCI, all the batches, I am very much over there. So you can connect with me for any kind of academic assistance required. I'll be more than happy to help you out for anything you want. Okay, so I wish you all the very, very best for the upcoming NEET examination. Stay focused, stay on track, stay consistent, and believe in yourself. You are going to surely make it. All the best, everyone.